بسم الله الرحمن الرحيم. Okay, Ahmed. بسم الله الرحمن الرحيم. We're going to start our webinar today. It's pediatric oculoplasty. I'm glad that we have with us Dr. Brian Costin from Cleveland, Ohio, United States, as well as Dr. Ali Abdelrazak from Ibn al-Haytham Hospital in Baghdad, one of the largest eye hospitals in the area, as well as myself, Assam al-Touhi from Cairo, Egypt. We are going to discuss 4 topics. I will start with orbital cellulitis. Then Brian will talk about a new technique for lateral tarsorrhaphy in epiblepharon. Dr. Ali will then speak about pediatric proptosis. And then I will end discussing the Frontalis muscle surgery and its types. We are glad that all of you are participating. Please mute your sounds. There is a chat room. You can ask questions, send questions. And at the end, we will have a discussion of the 4 topics. Let me start discussing orbital cellulitis. And why did I choose? I'm sorry, in the beginning, I need to declare royalty from Springer. Okay. Why is orbital cellulitis a topic that we need to discuss it in the pediatric age group?
Assam, would you please enlarge the screen? Slideshow. Thank you.
Orbital cellulitis is an emergency. So it can come at any time and it needs urgent treatment. We don't have the luxury of going back and reading and looking for answers. It is one of the topics that must be always in our minds. It's also life-threatening. Orbital cellulitis, as we're going to discuss, can lead not just to blindness, but to permanent neurological damage up to death. Consequently, it's important for our work, and definitely for the young generation. It's a very hot topic in exams. Usually exams would ask about emergency cases and life-threatening cases. In the pediatric age group, orbital cellulitis, as we're going to discuss, differs from adult age group in the presentation, sometimes in investigations, and definitely now in the treatment, because of recent advances and recent knowledge that we knew about the etiology and the treatment. We have preseptal and orbital cellulitis. The difference between them is whether the inflammation and infection is anterior or posterior to the orbital septum. Preseptal cellulitis usually occurs in a younger age group, less than 5, while the orbital cellulitis, the postseptal, is a bit older, around 6 to 7 years. And as I said, blindness can result from orbital cellulitis between 7 to 20 or 25% of the cases. And this is
Assam, please, no sound. Please unmute yourself. It's okay now. You can.
Do you want me to repeat from the start?
Yes, please. Just the last. No, from the incidents.
Okay.
Yes, from this one.
Okay. The difference between preseptal and orbital cellulitis is whether the inflammation and infection are anterior or posterior to the orbital septum. The Pre-septal cellulitis occurs at the younger age group, usually less than 5, while the post-septal occurs in around 6 to 7 years of age. And as I said, it's life-threatening. It can cause blindness in a range between 7 to 23 or 25%, which is a high number. When I was a resident, as I said, we used to have a case at Cairo University Hospital every day or every other day because Haemophilus influenza was endemic and causing upper respiratory tract infection and sinusitis, and this can easily spread to the orbit. This has dramatically changed because of the widespread vaccination that is routinely administered by law to all children. So orbital cellulitis has changed essentially, the first because the organism has changed. Now the common pathogens are the same, the bacteria, group A, streptococcal and staphylococcal, but other organisms have started to arise when Haemophilus disappeared. Fungal infections, especially in children with diabetes, with leukemia, or on long periods of steroid treatment, and less often after trauma, whether orbital or penetrating, or after surgery, especially strabismus surgery. But more importantly now, what is on the rise is the oncogenic origin of orbital cellulitis. Orbital cellulitis that spread through the maxillary sinus coming from the teeth. This has now represents about 10% of the reported cases. And this is a very special type and a very severe type of orbital cellulitis. A lot of children would go to the dentist, would have work done on their molars or premolars, on the upper jaw, the maxillary jaw, and infection occurs and can easily spread to the orbit, whether directly through the pterygopalatine fossa and infratemporal fossa and the inferior orbital fissure, or what is more important is through the veins of the orbit, thrombophlebitis. And we all know that the veins of the orbit are valveless, so they allow spread of infection in both directions, and this has still significance. So oncogenic infections are now on the rise. Clinically, orbital cellulitis is an infection of the orbital soft tissues, and the kids will represent with lid edema and ecchymosis, conjunctival injection, chemosis of the conjunctiva. Up to this stage, it can still be preseptal, but involvement of the postseptal structure and appearance of orbital sign, proptosis, optic neuropathy, pain with the eye movement due to the muscle affection or even motility deficits. Constitutional symptoms, fever and leukocytosis, are variable. To differentiate between simple orbital cellulitis and the occurrence of abscess, which is a very grave sequelae of the condition, we have two important signs now. Extension of the edema beyond the eyelid margin and leukocytosis with more than 10,000 neutrophils. These two signs are risk factors for orbital abscess formation. And these are two of the signs that all residents and all oculoplastic surgeons must usually look for when you are examining a child with suspected orbital infection or orbital abscess. The clinical picture can be a clue to the diagnosis, but imaging is a must. Why? For so many reasons. We need the image to evaluate if there is a subperiosteal abscess or not, and this occurs in mostly half of the cases. We have to image to assess the cavernous sinus and whether there is cavernous sinus thrombosis or intracranial extension of the infection. We said that the ophthalmic veins are valveless. They connect directly with the cavernous sinus. so infection can spread very easily and result in ophthalmoplegia and severe constitutional symptoms. And this is one of the differentiating factors between simple orbital cellulitis or even subperiosteal abscess and intracranial extension, is the constitutional symptoms. If the child is delirious, if the fever is very high, then you have to suspect intracranial extension. To rule out the neoplastic muscurat syndrome, we all know that some of the malignant tumors in children, like rhabdomyosarcoma, like metastatic neuroblastoma, or even leukemia, not only present as a mass in the orbit, but can even be associated with inflammatory manifestations. And we can start treating them as orbital cellulitis while the underlying lesion is a malignant tumor. So we need to do whether a CT or an MRI, and this will show the classic inflammatory reactions in the orbit, the fat stranding. All the orbital planes will be vague. You cannot differentiate with what's intraconal and what's extraconal, and edema of the extraocular muscles. These are some photos. This is orbital cellulitis complicated by cavernous sinus thrombosis, and you can see here is the enlarged superior ophthalmic vein. That's a very important structure to look for while doing CT or MRI. In all orbital cuts, you have to look for the ophthalmic veins. And in orbital cellulitis, it has a significant importance if this is dilated or enlarged. That's another case. If you just look at the photo, this will look, a lot of people will say this is just infection, preseptal or postseptal orbital cellulitis. But when you do the CT, there is a mass. That's a tumor that is masquerading as an inflammatory reaction. This is the third value of the CT or MRI, is the subperiosteal abscess. This is a patient who has an abscess in the upper part of the orbit, possibly coming from the frontal sinus. And I'm sure you all know now that all modern CT apparatus can measure sizes and volumes of any structure. This is called CT volumetry. And this is critical now in orbital cellulitis, as we're going to discuss later. I'm just here showing an example of how the CT can give you the dimensions of any mass or structure. Now let's move to the treatment and see what changed in the treatment of orbital cellulitis. Patients should be admitted, and we should start by broad spectrum intravenous antibiotics. It's very difficult to get a culture or to get a specimen. So we have to start empirically with broad spectrum antibiotics. If there is a subperiosteal abscess, based on the age and the other risk factors that we're going now to discuss, we should drain. And here is a question. Why don't we drain all cases? The periorbita is a very tough structure, and it's a very good barrier. When we drain and penetrate the periorbita, this can result in more damage and more spread of the infection. And always when you are in oculoplasty, we try to preserve the closed compartments as closed as possible to prevent spread of infection or spread of malignancy. So the mere presence of a subperiorbital abscess does not indicate drainage, as we are just going to discuss. We have now indications for drainage of subperiosteal abscesses. First one, if the abscess is more than 10 millimeter in diameter or its volume is more than 1250 millimeter by CT volumetry. So it is critical when you're sending the patient to do the imaging is to ask for measurements and try to make this a routine actually in oculoplasty. You tell your radiologist, if there is a mass, I would like the diameter, the dimensions, and the volume of the mass. in orbital cellulitis, if the mass is more than 10 millimeter or its volume is more than 1250, then this is an indication for drainage. Actually, this is the first indication. Then we divide the children into categories depending on the age. If the age is younger than 9 years and there is no optic neuropathy, we observe. Why? Because evidence-based had showed that this is usually strep or staph, and they are good respondents to the antibiotics, and there's a very high possibility of resolution on medical treatment. If the children are older than 14 years, we need to drain the abscess. We treat them like adults. In adults, by the way, we always drain the abscess. So children older than 14, we will drain, because mostly this is a polymicrobial infection, and probably there's an anaerobic component. And these cases do not resolve on medical treatment. So we have children who are younger than 9. We have children who are older than 14. What about in between? Children between the ages of 9 and 14. We only drain if there is a high risk factor. So we need to study and know by heart what are the high risk factors. Again, children below 9, we wait and give medical treatment. Children above 14, we drain. Between 9 and 14, we look for the risk factors. The risk factors are frontal sinusitis. So the infection here is not coming from the ethmoid or the maxillary, it's coming from the frontal sinus. If the abscess is large and non-medial, medial abscesses are coming from the ethmoid and are usually slowly growing and they respond well. If we have a non-medial large abscess, that's an indication for drainage. If we suspect anaerobic infection coming from the dental surgery, or if we see gas in the orbit, air in the orbit, because air in the orbit is an indication of anaerobic infection. If the patient is known to have several repeated attacks of sinusitis, because the response to antibiotics has been modified by the regular treatment of antibiotics with each attack of sinusitis that he had before, the organisms are probably now resistant. If this was a previously drained abscess and recurred, and definitely, finally, if there is any evidence of optic neuropathy. These are 6 risk factors. If you find any of these risk factors in the age group between 9 and 14, you need to drain this abscess. So again, any abscess that is large in diameter by volumetry, this is for drainage. Children younger than 9 without optic neuropathy, you can wait and for the antibiotic therapy. Children older than 14, you should drain. Between 9 and 14, you wait unless there is one of the high risk factors, as you can see. These are some photos. This is frontal sinusitis causing orbital cellulitis. This is a high risk factor. This is called sometimes Pott's puffy tumor, and this is an indication for drainage. This is medial subperiorbital abscess. And as we said, the medial abscesses, we can wait. The patient has very mild constitutional symptoms. This patient can respond well. He's younger than 9. These patients, we admit to the hospital, we start with antibiotics, and we wait. This is a case of air in the orbit. That's anaerobic infection. This is an urgent indication for drainage, for 2 reasons, actually. First, because the presence of air in the orbit causes compartmental syndrome. It raises the pressure in the orbit. And this results in compression of the optic nerve, rapid compression. Second, because anaerobic infection does not usually respond to the antibiotics. So dental origin, anaerobic infection, air in the orbit. These are some of the best indications for urgent drainage. How do we drain? That's the last point. The easiest, the safer, is to go to the orbit transcutaneously, whether subciliary incision, if it is a lower abscess, upper incision, if it's coming from the frontal sinus, lid crease incision, or Lynch incision, if it is medial. Although this is the most difficult, you have to go through many layers. However, it is the safer, particularly in an emergency condition, particularly if you are not an expert in oculoplasty. Safer, go through the skin. Theoretically, and a much easier way is you drain through the sinus, through the nose, endoscopically. And this technique has the great advantage of not cutting through the periorbital. However, this is the most dangerous technique. Why? Because tissues during the inflammation and the infection are usually less recognizable. And what happened many times is that the ENT surgeon, while draining the abscess, he just penetrates the orbital septum and the periorbita, and he starts injuring the orbital structures. We have reported 5 cases of optic nerve injury during endoscopic approach. One of them, we have a classic picture of the punch eating a piece of the optic nerve. So although the endoscopic approach theoretically is an excellent approach, it needs very high skill, and it is the most dangerous approach. And classically, it's not the type of the approach that we use in emergency situation. An in-between approach is the transconjunctival, whether through the inferior fornix or through the caruncle in medial lesions. Usually, it needs an expert in oculoplasty, but there is no cutaneous incision. You don't afraid of having a sinus or a fistula later on. So if you can get your oculoplastic colleague, then do a transconjunctival or a transcaruncular. In all cases, you have to collaborate closely with the ENT surgeon, because it might be advisable that he drains the sinus during the same procedure and the patient is not admitted to the OR twice. I hope that this has been helpful. Thank you all, and back to you, Ahmed, please.
Thank you, Dr. Assam, for this nice presentation. Any question, we can write in the chat or raise your hand and you can discuss with Dr. Assam. Okay, Dr. Assam, we can shift to another talk with Dr. Calvin.
Let's start with Brian and Dr. Ali. And
Brian,
then we'll...
okay. Dr. Brian, you are ready. You can share your presentation.
Can everybody hear me?
Yes.
Okay, let me get my PowerPoint up.
Okay, you can share now.
Sorry, Dr. Ahmed, can I ask Dr. Assam a question?
Yes, of course.
While Brian prepares the slides, Dr. Assam, what is the favored empirical antibiotic therapy that you use in orbital cellulitis?
Okay. Usually we start with a recent generation of the cephalosporins and add to it gentamicin or garamicin.
Thank you, Dr.
All right, Ahmed, how do I share my screen? Can you walk me through that?
Yes, there is icon down, green icon down, share screen.
I see.
you can press on it and then you select your PowerPoint presentation.
There's a question, Dr. Harma from Jordan, I think, raised his hand. Dr. Ahmed, can Dr. Samir from Jordan, I think he needs to have a comment.
Hello, can you hear me, Dr. Assam?
Yes, Ahlan, Dr. Samir.
Thank you, thank you. Dr. Assam, I want to ask you about your antibiotic coverage. I would prefer personally to have something to cover the gram-positive and the staphylococcus. The combination which you mentioned looks to me doesn't cover this, because you mentioned cephalosporins and garamycin or gentamicin. So you are covering the gram-negative very well, but I'm afraid the vancomycin might be a better addition to third-generation cephalosporin. That's my personal impression. What do you feel?
Thank you, sir. This is what usually works for us. Probably what you said can be good in other places, but this is our starting point. We put the patient on intravenous for 24 hours. If there is a good response, we continue. If not, we start changing the antibiotic. However, this definitely varies from one place to the other.
All right. Okay. Thank you, Dr. Sam. Good luck.
Thank you, sir. Thank you, Dr. Sam.
Okay, Dr. Iman. Accept, unmute Dr. Iman, and you can talk. You can talk now, Dr. Iman. Welcome.
Dr. Assam, thank you very much. And I want to ask you regarding your experience, why we can see some patients suffering from optic neuropathy and the loss of vision in orbital cellulitis.
For two reasons: spread of infection to the optic nerve and the sheath, and the compartmental syndrome, the rise of pressure inside the orbit.
And is this enough to lead to an OPL and the loss of vision?
Yes, it's like orbital hemorrhage. Sometimes even just orbital hemorrhage can cause compartmental syndrome.
So you mentioned that it is related to the pressure effect. It is a sort of compression
Both.
on the optic nerve.
Yes, both the compression and the spread of infection. Both,
okay.
Both are dangerous.
Okay, thank you. Thank you.
Thank you,
Okay.
Dr. Iman. So Brian, you can start now. Just enlarge your presentation.
Sure. Okay, let's see. Okay, can you guys see the PowerPoint? Am I sharing? Okay, thank you. First, I'd like to thank everybody for being here. I'd like to thank Dr. Assam for inviting me and for a really nice, succinct review of that problem, which we don't face as often, as he mentioned, as was historically faced, but certainly when it happens, it is an absolute emergency, and really time is vision, to use the cliche in ophthalmology. And then I think another interesting point that Dr. Assam made was talking about Haemophilus, and I think it's especially important during the times we live in now, with concern of contagion, to just illustrate how much science, observation, hard work, research can result in vaccine. So I'd like to thank him for bringing up the change in microbacterial profile that occurred with orbital cellulitis, because he's absolutely correct. I mean, Haemophilus is a rarity now. So very interesting talk. To switch gears a little, I'm going to speak about something that's far less common and certainly far less threatening to the vision, but is a technique that I really enjoy and I feel really works well. I'm hoping to publish something about this technique in the coming year. But basically, it's a straightforward, potentially in-office treatment, surgical treatment for uriblepharon, which I only see 1 or 2 times a year, but can cause significant functional and cosmetic disturbance in the pediatric population, particularly in the later mid to late teenage years. Uriblepharon, as you recall, is a congenital eyelid abnormality. It's a bilateral one. It's pretty rare. And it consists of it's kind of grouped into the ectropion category, but really it's a distinct entity unto itself. It's a horizontal enlargement of the palpebral fissure with a vertical foreshortening of the lid, and then this really almost interesting lateral, specifically lateral canthal ectropion and lid malposition, specifically a dystopic location of the lateral canthal angle displaced inferiorly. And it almost, I'm sure you've all seen it, almost forms almost like a pool in the lateral canthus. So certainly a distinct, perhaps subtle, but distinct phenotype when you see it. The consequences for the patients that have this condition are mainly epiphora, and specifically epiphora down laterally, as well as sometimes exposure symptoms, although in my experience that's not as common. Perhaps it's because of the pediatric population and their relative resistance to exposure. But certainly cosmesis. You know, this phenotype can present some real challenges to self-confidence, self-esteem, et cetera, because of the perceived unattractiveness in many patients will tell you about. And so how do we address this issue? And you'll see multiple techniques in the literature. And frequently it's the go-to lateral canthal resuspension. But I've seen some reports that involve cheek lift or mid-face lift, combining with the lateral canthal resuspension. And I'm sure that severity of the lateral ectropion factor in there. But what's certain is that these Can you guys hear me?
Yes, we can now.
Okay, where did I cut off?
Please repeat the last one.
Talking about the surgical technique I'm presenting.
Okay.
Is that where I was?
Okay.
Okay, so I like this technique because
we didn't see your PowerPoint sharing now. Please share it again.
Oh, sure. Can you see now?
Yes.
And do you recall, is this the slide I was on?
Okay.
Okay. So I like this technique because it's possible even to do it in the office. But if it does involve the operating room and anesthesia, the amount of anesthetic and the time in the operating room is reduced compared to a lateral canthal resuspension. There's really no visible scar, and should it be necessary, the procedure is reversible. So what is the procedure? This is a illustration of, it's supposed to be a lid with a uriblepharon. And is my pointer appearing here? Yeah. Okay. So the illustration is supposed to show you that there is a lateral canthal malposition with the palpebral fissure pointing kind of downward, as well as a lateral ectropion with the epiblepharon. So the procedure involves an incision made along the gray line. I typically use a 15-degree blade. And prior to this, regardless of the level of consciousness, I've instilled topical drops and then prepared the area with betadine. And that's after I've instilled maybe 1 to 2 cc's of 1% lidocaine with 1 to 100,000 epinephrine. I usually do about 5 injections. I'll do 1 in the skin of the upper lid, 1 in the skin of the lower lid, at the lateral canthus, kind of balloon that area up. And then I'll actually use my finger to evert the lid from the globe so that my lid is completely away from my globe and there's no concern for any kind of ocular damage, because people can jump during this particular part. I feel like when you introduce the 30 gauge needle through the gray line, it's a whole different level of sensory nervous innervation, and people can really jump. So I really like to evert the lid and then introduce an injection through the gray line of the upper lid and then through the gray line of the lower lid. And again, we've prepared the area with betadine after instilling topical anesthetic drops. And then I use a 15-degree blade and I make an incision in the gray line. And I calculate how many millimeters of a tarsorrhaphy, typically no more than 3, usually 1.5 to 2 millimeters of the lower and upper lid that I'll be joining. And then I grasp the tissue posterior to the gray line, the mucocutaneous junction, with a 0.5 millimeter forceps. And then I will use Westcott scissors or Van Ness scissors to excise the mucocutaneous junction posterior to the gray line. And basically what I'd like to do here is form a bleeding edge so that we'll have a nice scar tissue bridge form. I kind of turn the corner so that this entire area is bleeding and prepared to make the tarsal adhesion that will form the basis of the tarsorrhaphy. Once that tissue has been bared, then I personally really like, usually I use Ethicon suture, but in this particular case, the Covidian 6-0 polysorb suture, I really like. It has a better profile in my experience of being absorbed by the body. Sometimes the Vicryl suture of the Ethicon brand, which is what I actually prefer in most circumstances, I find does not absorb as well, and it's a little thicker, and I always am concerned I'll have a little nidus for infection, although I maybe have had one infection that I can think of from this procedure. But basically what I'll do is pass the suture through the superior aspect and then the inferior aspect, and then we'll tie down the suture laterally so that the knot is obviously away from the cornea. And then the patient is discharged. I've never prescribed painkillers for this, or pain medication or opioids or anything. They'll be instructed to place some antibiotic ointment on that lateral canthus for 4 times a day for 7 days. I usually just use erythromycin unless there's an allergy. And then I have them return at 1 month for feedback. Is their tearing better? Are they happy with the way it looks, etc. And then I wanted to give you guys a photo from the clinic, but unfortunately none of these patients I had consented for photography to use in a platform like this, unfortunately. But should the opportunity arise, I can definitely do that. But I'm sure you can probably gather that I think really what happens here is that the upper lid, should it not be ptotic, really acts as a kind of a cantilever to pull the lower lid up and restores almost like a true angle to the lateral canthus, so it's not downturned. And then as well as I think it tightens the overall palpebral fissure. So, you know, if you think about what we're doing here, if we're decreasing the size of the palpebral fissure by 2 millimeters, Well, that means that the globe has a smaller aperture to protrude through. Therefore, you would think that the pressure between the lid and the globe would be kind of increased. It's similar to what Dr. Assam was saying about the pressure in the orbit from a hemorrhage or cellulitis, although the difference being that we're not increasing the pressure of the orbit, we're just decreasing the palpebral fissure size. But basically, what I think happens to correct the lateral canthal ectropion is that we now have a better apposition through pressure of the globe to the lid. And so, and really an added benefit of this is it's just so straightforward, and the patients, these teenagers who you know, are kind of self-conscious of this, get such a boost in their self-confidence and their self-image. And the flip side of the coin is they've really had to undergo very minimal work. So kind of the parents are happy, that the child is happy, and certainly not the answer in every case of epiblepharon. I will say, in my experience, I've not had one that didn't respond to this, but we are talking about an N of probably 15, 16. So small kind of case series, but I have found it a very valuable technique. And then worst case scenario, should it not work, hypothetically, all that has to be done is the area is infiltrated with local anesthetic, and then the tissue bridge is lysed, and then that mucocutaneous junction really returns to what it was before. And we see this all the time with our patients we temporize with thyroid eye disease or other forms of Bell palsy or other forms of exposure. So so in summary, it's nice because there's no scar. It's really, the scar is between the mucocutaneous junction. It's not in the epidermis. It is a reversible procedure. It does minimize our use of anesthetics and incisional surgery, which certainly are safe in the pediatric population, but if it can be minimized, it's always something to consider, and then do result in a nice cosmesis. That's all I have.
Thank you, Dr. Brian. Dr. Assam, any comment?
Thank you so much, Brian. This type of tarsorrhaphy, the trace tarsorrhaphy, is a very good procedure, actually. And as you said, it can be used in many indications, blepharophimosis syndrome, post-traumatic. So, and it's very simple. So thank you so much for showing this to us.
My pleasure. I'm happy, if there's any questions, I'm happy to take questions.
From Dr. Samer Khorma from Jordan, you wanted to comment?
Yes.
Dr.
Thank you. Dr. Brian, thank you for this brilliant procedure, which helps a lot, really. My question to you is, what do you feel is the perfect timing for treating epiblepharon? And what do you consider the golden standard, let's say perfect, ideal, best technique which you can do for the child? Because as you mentioned, it's so much cosmetically embarrassing. It's also functionally a very big challenge, and people tried all sorts of things, lateral canthal tightening, skin grafts, maybe mid-facelift, as you mentioned. What do you feel the golden standard practice nowadays? Thank you, sir.
Oh yeah, thank you very much. Well, I think that, you know, when we talk about gold standards, I personally always look to, you know, the text books. And so, you know, if you look at, you know, kind of the textbook, kind of our oculoplastics text, the overwhelming answer would be lateral canthal resuspension, which I think I can probably speak for everybody is one of our favorite tools. And whether it be used in an entropion repair, an ectropion repair, a cheek lift, what have you, it's just the healing powers of the lateral canthus are really remarkable, especially when we compare it to the medial canthus. Anybody who's done some cancer work will agree, I'm sure. But the answer is the gold standards, from what I've determined, is lateral canthal resuspension. I will caveat that by saying that I think we're in a time where we're all kind of certainly building on the experiences of the past. And to go back to what Dr. Assam said, you know, whereas Haemophilus was a problem a real significant problem, and now is not as common. I think we're all kind of looking at procedures that perhaps can reduce anesthetic, can reduce costs, can reduce all kinds of things. So I'm certainly not saying this is the gold standard, this trace lateral tarsorrhaphy, but what I am saying is it's a nice thing to consider because it is, as Dr. Assam said, technically straightforward and does minimize some risks to the patient and is reversible. And then to answer your second question, which was when is the perfect timing? I feel like with epiblepharon, it's one of those things, it's like a coming of age problem where certainly they've had to deal with tearing, et cetera, but I find they usually present to me around 14, 15 years old. And I found that females typically present a little bit later than males, interestingly. And again, this is an anecdotal N of probably 15, but when I reflect on these patients, this is what I feel. And so I think they probably present mostly when the cosmesis is coming to their young minds, how they look they're starting to look in themselves in the mirror more and think about all kinds of things that will face them as young adults. So I think that when they come to you and when the parent comes to you and says, hey, this has been a problem lately, and then obviously the tearing is something else to consider. So I think the short answer is kind of when they present to you.
Okay, thank you, Dr. Brian. Dr. Assam, let us go back to your presentation, and I have two questions in the chat. The first question: how long should we wait for subperiosteal abscess to resolve by medication? For how long before the drainage?
48 hours, provided there is improvement. يعني if after 24 hours it's not improving, then we don't wait. يعني عشان كده قلنا the patient should be admitted. And we examine, we look for the optic nerve functions, and we look for the improvement.
Okay, what about the role of metronidazole in orbital cellulitis?
If you are suspecting that the organism is responding, yes. يعني, we said that the first choice of antibiotic is empirical. So it will depend on the judgment, on what do you think is the reason and where is the source of infection.
Okay. According to the suspicion.
Sure.
Okay. Now we will shift to Dr. Ali Abdul for his presentation, but I think he has question before he started his presentation. He can ask, and then he share his PowerPoint and start his presentation about proptosis. Dr. Ali, you can.
Okay, just a small question for Brian while I start my presentation. You said you removed the suture after 1 week, or you just leave it to disintegrate, or?
Yeah, I let it dissolve, and very rarely when I've used this technique for other purposes. I mainly use this technique. I have a growing cosmetic clinic for this purpose, who likes a small lateral canthal elevation with minimal commitment to surgery. And then also I use this technique for Graves, for Bell palsy exposure, and then actually for a group that I use for epiphora, functional epiphora. So in the presence of an open patent nasolacrimal system. So when I pool because the technique is the same, when I pull those numbers into my experience for this technique, I would say that almost no one requires the suture to be removed. And if it does require removal, if they feel like they can, have a foreign body sensation, it's quite easy to do at the slit lamp. So it's usually not an issue.
Amazing. Thank you so much. That was brilliant.
Oh, my pleasure.
Okay, Dr. Ali, you can start now.
So it's clear now for you? You can see everything?
Yes.
Okay. So I'm glad, it's a pleasure, it's an honor to be here. I'd like to thank Dr. Assam for inviting me for this precious opportunity to be with him and Dr. Brian. So proptosis in children. Now, first of all, I have no financial interest in this talk. in the pediatric ophthalmology department where I work, we're occasionally presented with a parent who brings his child saying, "Doctor, my child's eye is bulging." For anyone, especially my residents, when they see it, they are frightened and they rush the child to me. So is proptosis in children a different story than what we see in adults? Well, actually, yes, it is. Because first of all, there's a significant number of proptosis in children, which is due to congenital or developmental anomalies. And these developmental anomalies, they could be confined to the orbit, or they could be a part of a craniofacial abnormality that we see in Cruzon and other other diseases. On the other hand, acquired proptosis in children can be sometimes alarming and an emergency, just as Dr. Isam said. Orbital cellulitis is one of the top ophthalmological emergencies that we may encounter. Now, in order to deal with proptosis in children, as in any clinical entity, you need a clinical stepwise approach. So, although it is an unusual problem, but it is a problem that requires urgent evaluation. So, as in any clinical condition, you need the history, the clinical examination, and the imaging. Now, regarding the history, first of all, it's very important to know the age of the onset. And sometimes if you do not know the age of the onset, photographs can be very, very useful here, especially when dealing with children, because sometimes the family will not recall when it started. At the same time, the rapidity of the onset, or how rapid it evolved, and how long has it been there, is very important clinical sign that may lead you to the diagnosis. Also, the lethality of the condition, because a bilateral proptosis, for example, in early infancy, may be due to orbital shallowing in craniofacial malformations, while a unilateral proptosis that has evolved, for example, rapidly, may be a sign of an intraorbital mass. And also the associated symptoms, the presence, we will go by this one by one, the presence of fever, or for example, generalized fatigue and other systemic symptoms. Now, when we come to the age of the onset, I found it in many literatures and many textbooks that it is more convenient to divide the age of the onset of proptosis in children into three age groups. Either it's from birth up to 4 years, from 4 to 10 years, and from 10 to 16 years. I'll tell you later on why this is important. Now, from birth up to the age of 4 years, in this group, we may find mostly capillary hemangioma, lymphangioma, an orbital cellulitis, as Dr. Isam mentioned earlier, a dermoid cyst, a craniofacial anomaly, a teratoma. Now, as we can see, most of these in common, what they share in common is they are mostly, let's say, non-malignant conditions. But always bear in mind that in this age group, retinoblastoma could present with proptosis if it is long-standing, especially in our areas. I know that in the United States, where Brian is, that they do not usually present early, but in our areas in the Middle East, usually they present to us late, like these two presentations here. Also, bear in mind, rhabdomyosarcoma, although it is not very, very common in this age group, but it may be also a presenting sign. On the other hand, when we go to this age group, between 4 to 10 years, in my opinion, this is the most dangerous group that you may encounter when you have a child with proptosis, because in this is the age group where you'll encounter the malignancies. This is the age group where you may see rhabdomyosarcoma, which is more common in this age. You may find an optic nerve glioma. Leukemic deposits are also common. Also, you may find other causes such as AV malformations, Langerhans, histiocytosis, also orbital inflammatory diseases and cellulitis. They may be found here. But bear in mind when a child comes to you with this age group, do not always keep this very dangerous condition in your mind. On the other hand, when we shift to the older age group, up to 16 years, we find the inflammatory conditions or the systemic diseases that may be associated with proptosis, such as non-specific orbital inflammatory diseases, thyroid orbitopathy, dermolysis also may be found here, but always think about leukemic deposits. In other words, keep this categorization of the proptosis according to the age group in your mind when you encounter the child with proptosis. It may give you a broad idea about what's going on, but always do not rule out the serious things. Always, you must think about, when you have a childhood proptosis, think about the associated systemic diseases. For example, you may have primary orbital tumors such as rhabdomyosarcoma, or metastasis in leukemia and neuroblastoma, and also optic nerve tumors such as optic nerve gliomas. And always think about thyroid, because a child also this thyroid ophthalmopathy, although it is not very common, I have not seen a lot in the hospital, but it is a presenting sign. And always remember the craniofacial malformations, which are also associated with other systemic diseases. Now, going on to the next step is the laterality of the disease. Laterality is important, as I mentioned earlier, because, as I said, craniofacial abnormalities may, you can see here in Crouzon syndrome, and inflammatory diseases, as in thyroid, as you can see in this little girl here. And while in unilateral, you can see here this huge optic nerve glioma compressing onto the optic nerve, and you can see the unilateral proptosis. So when it's unilateral, think about a mass effect. When it's bilateral, think about more of a systemic disease. The rapidity of the onset, maybe this is the most, this is the key factor actually when you're dealing with proptosis. This is the most clinical sign that will give you a clue, a closer clue to what's going on. So if it is a slow growing proptosis, let's say over weeks, mostly this is a benign condition that we may see, for example, in dermoids or orbital dermoids, because they are usually grow very slowly. While rapid proptosis that evolves over days, we may see them right in capillary hemangiomas, but usually they are malignant. So always think about rhabdomyosarcoma, retinoblastoma, neuroblastomas. While catastrophic or all of a sudden of onset of proptosis are usually due to a bleeding in AV malformation or an orbital cellulitis, but always do not rule out malignancies here. So as you can see, when I'm going through my talk, I'm always saying when you have any differential diagnosis, do not rule out a malignancy, because you may be dealing with something very simple. On the other hand, you may be dealing with something that is very, very serious. Going on to, as I said, this alone should not be taken for granted. Always rely on the collection of data, of the clinical data on your examination, on the imaging that you will send, but always it's like the collection of clues, as if you're Sherlock Holmes and you are going to reach your diagnosis. The associated symptoms is an important aspect also that you should discuss or you should keep in your mind. Pain or local inflammation is a sign of inflammation. And if you find a child that is, for example, generally ill or febrile, this may be a sign of orbital cellulitis. Also, other signs of inflammation, such as limited ocular motility, may give you a clue. We may find that, for example, in orbital inflammatory disease. Skin discoloration and the type of discoloration is also important. Sometimes the discoloration, if it is more superficial, as in superficial capillary hemangiomas, they have this red color. While as it goes more deep or deeper lesions, you will have this more purple or bluish hue. Also, the presence of increasing proptosis while crying or straining may give you an idea that this may be the absence of the sphenoid wing, as you can see in neurofibromatosis. And as I said, limited ocular motility. In older children, diplopia may be an associated sign, although younger children usually do not complain of diplopia. Do not rule out pseudoproptosis. Always look for this before going to other things. If there is a lid retraction, if there is asymmetry in the size of the orbit, if you have a shallow orbit, for example, a large eye that you can see in unilateral high myopia or pathological myopia, or on the other hand, if you have a contralateral ptosis or microphthalmia. This is classic. We have read it always since we were junior doctors, since we were residents, the 6 Ps. Keep them in mind in the exams, keep them in mind when you're dealing with clinical cases, the pain, the progression, the proptosis, the rapidity of the proptosis, the palpation, when you palpate it, is it firm, is it soft? If it is firm, this could indicate a dermoid. If it is more soft, this may indicate, for example, capillary hemangioma. The presence of a pulsation, this could be transmitting AV malformation, for example. And always the periorbital changes. I just put there just to refresh our minds with this classic mnemonic. When we want to examine a child with proptosis, actually it's a different story. Here you're dealing with a child. The child may be intimidated by you. He may be frightened. Always try to make a friendly environment with the child, with the family. I always try to hold the toy in my hand, try to make a laugh with him, give him a sweet lollipop, for example. Sometimes photography, you can just take out your mobile phone and just to take a picture while the child is playing with his mom or dad. The best 2 views that you can obtain with proptosis is either the worm view from you elevate the chin and try to take the photograph from below, or the bird's view from above. Of course, both will work very fine. Both are classic views, but doing the photography may enable you to look at the proptosis or the picture of the proptosis in details more if the child is not very cooperative with you. Then you need a systematic examination. As I said, do not disturb the child. Try to establish a non-contact examination. Look at the globe position if there is any dystopia. Look for the ocular motility using the toy. Look at the lid shape. Is there any abnormality in the shape of the lids? And the other signs of inflammation. Doing this, this will open the door for you for a more detailed visual test. Doing the visual acuity, this is a key for your examination. The color vision maybe is difficult, especially for younger children. Pupillary reactions, you can do them, although that's not very easy. A cycloplegic fraction is important actually because it enables you to examine the fundus, to look out for any abnormalities in the disc or the retina, as we will see in a few moments. Visual field testing, although it is mentioned in the textbook, I don't think it is very applicable for children below 10 or 12 years, in my little experience. Always, as I said, keep in mind you're dealing with a child, and some of these examinations will be difficult to perform. After that, you can examine the proptosis by, first of all, examining the interpalpebral, the interpupillary, and also the horizontal fissure length by just holding a ruler over the forehead of the child. This will be very helpful in giving you the baseline measurements for the child. Also, it can be done using your mobile phone with the camera. If you can zoom in, take the picture, and then put the ruler on the image that you obtain from the camera. As you examine the proptosis, look, this is also a classic question. Is it an axial proptosis? Which indicates usually that there is a mass inside the muscle cone. As a convergence hemangioma, glioma, sometimes some meningiomas, metastasis also could be axial. and avial malformations, while non-axial proptosis are caused by lesions outside the muscle cone, leading to dystopia. And the side that the eyeball is displaced will give you an idea to where the pathology is. For example, if you have a superior displacement, this means that the globe is being pushed from below. This means that you have a problem or a pathology in the orbital floor. At the same time, an inferior medial displacement means that you have a problem in the lacrimal glands. And if you're lateral displacement, this means that you have something emerging from the frontoethmoidal areas. Then you need to examine the proptosis. If the child allows you, especially in older children, you can either use the Hertel. This is a classic method of examination. All the residents are obliged to know how to use the Hertel. And the Lud also exophthalmometer. It's also a very useful instrument. It has this transparent stand here with the ruler that allows you to measure the bulging of the eye. Then you go through systematic examination. The color of the lids, as I said, then the shape of the lids. You need to examine the lids. Put your hand over the lids to see if it's warm. Is there a pulsatile mass? Is there any lagophthalmos? Or on the other hand, is there any proptosis or lid retraction? Going through the ocular motility, it is also, as you can see, this child with orbital cellulitis. This is an indication. This actually is a differentiating sign between the preseptal and the orbital cellulitis when you have limited ocular motility, as you have here in this child. Always look at the sensation. If the child is intelligent enough, he will tell you. Always don't forget the tip of the nose. If you can take a cotton tip and try to see the corneal sensation. And these are the 3 areas that you need to examine for the trigeminal nerve. And going back through the lid, you need the systemic eye exam. Look at the conjunctiva if there's any chemosis. Look at the cornea to see if there's any deposits sometimes in amyloidosis, for example. Are there any abnormalities in the anterior chamber? If you can, put the child on the slit lamp. If I have a portable slit lamp, I have it in the outpatient department in the Haytham Hospital. Also, I have it in my private clinic. It's very, very useful to use. Look for any, for example, AC reactions, or also leukemic deposits can be seen in the AC. So, in some instances, then you need to examine the retina and the optic disc. This is a very, very important part of the examination. You need to see if there's any swelling of the optic disc, as you can see in this child here. Look for any choroidal folds, because some tumors or choroidal tumors that lead to proptosis. This may be an early sign, or it could be a late sign of involvement of the choroid. Then, actually, after all, you have done all your examination, you need to know which imaging you need to send the child to. You need a high resolution, non-invasive, as much as you can technique, and the use the new modalities of new imaging, the new MRI machines and the new spiral CT scans has deferred the need for diagnostic biopsy than we used to do 10, 15 years ago. But here you need to send the correct imaging modality for the appropriate patient, because an incorrect imaging modality or an inappropriate imaging section will lead to an inaccurate assessment, and it also have a financial burden on the family. The main 4 imaging modalities we have there: the CT scan, the MRI, the plain X-ray. It is also of use in certain areas in the Middle East. Also in my country, Iraq, we use it. And also the orbital ultrasound, although it is of limited use. Just a few words about the what to use and when. The CT scan, as we all know, it is we should request the CT scan for the orbit and intracranial views. It should have 0.75 up to 2 millimeter slice thicknesses. You need to obtain coronal and axial images. And if you need anything for the optic nerve, you need thin slices to be obtained. Each imaging modality has its pros and cons. The CT scan, it's readily available, it's very rapid and easy. Sometimes it will provide very, very important information about the intracranial and the bony orbital structures. It will highlight the calcifications, especially in tumors in retinoblastoma, if there is any ferromagnetic foreign body. And it can be used with contrast agents, although we need to be very careful when using contrast agents in young children because of its effect on the renal function. And if you have a cooperative child, you can use it without sedation. But young children still need sedation. The most important problem that you have with CT scan is the high dose of irradiation, and it does not give you very full details about the soft tissue structures if you need them. While the MRI, now it's, in my opinion, it's widely used more in orbital lesions, especially if you want to examine soft tissue structures of the orbit. The nice thing about it is that it has very high resolution and there's no exposure to ionizing radiation. And you can choose any plane during the time of examination. But always remember that it needs fat saturation techniques because the fat will obscure the, especially in T1, the image of the optic nerve. The problem with MRI, it's a long procedure. And this long procedure, usually because of the sounds of the claustrophobia that happens with children, you need sedation. Usually we use propofol or sometimes chlorhydrate. And because of this procedure, you need an anesthesiologist to be present with you in the MRI room. Also, it's contraindicated if you are suspecting a ferromagnetic foreign body, and it cannot image the bone for you. These lesions, if they are hyperintense on T1, they should alarm you. The presence of lipids, for example, in dermoids, the presence of mucus in epidermoid cysts, in subacute hematic cysts, in subperiosteal hematomas, and melanin in melanoma. I'm about to finish these last 3 slides. The plain X-ray. The plain X-ray is still of use because it is of low cost. It is readily available. You do not need sedation when using the X-ray. And it can localize some foreign bodies and also some bony abnormalities. Also, it is much more cheaper. And also, it is of good use in orbital traumas and also in sinus diseases in orbital cellulitis. Now, ultrasound, it is of limited use, I know, but as a screening tool, it is very, very valuable, especially when you have cystic lesions, such as in capillary hemangiomas. You can use the Doppler flow with the ultrasound to see the flow of blood in these vascular lesions. The problem with it is you cannot obtain deep imaging quality, and the lack of the high resolution that you can obtain with the MRI and the CT scans. I found this very nice. This is my last slide. This very nice scheme, and it's found in the Pediatric Practice of Ophthalmology by Greg Luda. It will show you a scheme, and it will be available. I'll give it to Dr. Ahmed for all the residents to show you this flow chart of how to deal very rapidly with a case of child with proptosis, whether it is chronic, whether it is rapid or mild gradual onset, and when to send for imaging. Thank you very much. Sorry for the long talk. I think the most famous cartoon that that had proptosis were The Simpsons. I hope everyone will stay safe in these hard times. Always never forget that love is what binds us all together. Thank you, Dr. Issam, for this massive opportunity. Thank you, Brian, for sharing this meeting with us. Back to you, Dr. Ahmed. Thank you so much.
Thank you, Dr. Ali, for this nice presentation and important topics, especially with this young age. how to deal with case of proptosis, because as you said, we
Hello.
Hello, Dr. Assam. We
Can I start? الصوت كان
you can.
Thank you Dr. Ali. يعني I liked very much the way of organizing proptosis according to the age of the child. We always deal with children as if they are one unit, while they are changing. Every year is a total different physical and physiological person الحقيقة. I also want to mention one point that you said about the CT scan. I want to remind everyone that when you're doing a CT scan on any part of the body, you can do it with contrast or without contrast, and usually they do both. So they do it first without contrast, then they inject, and then they do it again after injecting the contrast material. This is contraindicated in the eye in general, and especially in children. Radiologists do not submit the eye, and particularly in children, to double dose of radiation, because mostly of the fear of the cataract formation on the lens. So CT in the eye, you have to specify from the beginning, do you want it with contrast or without contrast? A lot of us don't do this distinction. They just send the patient to the CT and they think that both will be done. No, please, you have to decide, because only one of them will be done to the patient. It's either with or without. Thank you. Now I would like to discuss a very common, frequent, and important procedure, or several procedures that we usually do in ptosis. Again, ptosis is the bread and butter of oculoplasty. Actually, the whole subspecialty of oculoplasty started by ptosis surgery. Frontalis muscle. We usually speak about frontalis muscle. We operate on frontalis muscle. We do a lot on frontalis muscle. And I want to discuss with you several issues about the frontalis muscle that might help broaden our thinking and our techniques while doing these types of procedures. Again, I have a connection with the Springer. Okay. The first thing is that the worst thing actually that we do as surgeons is that we concentrate on how to do a procedure without realizing and thinking, why do we do the procedure? We all try to manage and skill the steps and the suturing and the aspiration of the lens and the peeling of the membranes, but we never stop and ask ourselves, why is this done? What is the importance of each of these steps? So I want to start with the frontalis from the beginning. Why do we use the frontalis in ptosis surgery? It's never the first option, because using the frontalis, we are actually changing the whole physiology of the lid. We usually elevate the lid with the levator contraction. We usually close the lid by relaxation of the levator with help of the orbicularis in the tight closure. So it is the levator which is the single most important muscle of the lid. The frontalis is never in action normally for elevating and closing the lid. What we're doing in this surgery is that we are changing the physiology to a non-physiological mechanism by which the lid will elevate with brow suspension and contraction of the frontalis, and will close by orbicularis contraction. And this is done by transmission of the frontalis activity to the tarsus of the upper lid, which is the skeleton, by insertion of a non-stretchable rod-like structure between the two. When do we need to do the frontalis muscle surgery? The single most indication that all of us know is when the levator function is less than 4 or 5 millimeters. There are some other indications. We can use it as a temporary measure. If we cannot get proper measurements of the lid movement, of the crease, of the levator activity, and there is a fear of amblyopia, many people would advise doing a temporary frontalis sling until the child is old enough to take good measures. And sometimes we do this in cases like blepharophimosis, for example. Another indication is after failed maximum levator resection, irrespective of how much is the levator function, we resort to frontalis sling. But one of the first questions that we notice in doing frontalis muscle surgery is why, if the levator function is poor, 4, 5, actually now it's moving up a little bit towards maybe 6, why don't we still try the levator, since it is the physiological muscle? If the levator function is weak, very weak, you can do levator surgery and you can do levator resection 22, 24, 25 millimeter or even more. And this will lift the lid up. And in this case, you're cutting the horns as well as advancing the Whitnell ligament. But the problem with maximum levator resection is that you are moving the lid from a dynamic structure to an immobile or a frozen lid. We are using the frontalis instead of the levator in these cases, because if we use the levator, the lid will be frozen or immobile. If we don't understand this issue, we will do the frontalis surgery in a wrong way. Because if you end up doing the frontalis surgery and getting the lid frozen or immobile, then you've lost the whole issue of the frontalis surgery. Again, we resort to the frontalis surgery because we don't want to do a maximum or supramaximum levator surgery, because this will make the lid frozen or immobile. So I don't want the frontalis muscle surgery to end up with the lid frozen or immobile. The Arabic word or the Egyptian word for frontalis muscle surgery, the old word was بنعلق الجفن. No, this is not what we want to do. We don't want to have an immobile lid, even if it is an open lid. We have to answer first several questions about this frontalis surgery. Do we do a unilateral or a bilateral surgery? Again, the frontalis surgery will depend on opening the lid by contraction of the frontalis and closure by the contraction of the orbicularis. If the patient does not contract his frontalis, then the frontalis muscle procedures cannot be used. The brain usually does not want to keep contracting the frontalis because this causes headache, this causes pain. Any muscle that contracts for a long time, particularly if this is not its physiological job, the patient will develop pain and headache. So there must be a stimulus, a benefit for the brain to work the frontalis. Patients who have severe unilateral ptosis, no matter what you do, if you do the frontalis sling, still the patient will not be corrected. Why? Because the brain does not see any benefit of contracting the frontalis all day long. He's seeing out of the other eye. So frontalis sling for severe unilateral ptosis will always result in undercorrection, even if you have done the steps of the procedure correctly. The patient will be still ptotic because he can see out of the other eye. And this is what happens in the very famous condition of jaw winking. You all know that the book says that in jaw winking, you have to operate on both lids, even the lid that is not affected by jaw winking. Why? Because if you operate on just the lid that is affected by jaw winking, still the ptosis will not be corrected because the patient is seeing out of the other eye. So to achieve what you want to achieve with frontalis muscle, it's always advised to work on bilateral, on both eyes, even if the ptosis is on one eye. The very classic example is jaw winking, but even in unilateral severe congenital ptosis, when you are going to do a frontalis muscle procedure, you do bilateral sling. You don't have to affect or cut the levator on the normal side. Actually, you don't have to cut the levator on any side, but you have to do bilateral sling. And this must be documented before the procedure, and you have to work with the family, and you have to show them that the patient is using or not using his brow before the surgery, because after the surgery, if there was no stimulus, if the patient was not using the brow before the surgery, the result will be disappointing. Sometimes you occlude the normal eye to allow the patient to understand and his brain to understand that if he contracts the brow, he will see out of the ptotic eye, and this will stimulate the brain to try to use the frontalis. You can always do this also post-operatively. When the patient comes to you saying why the lid is not as high as it should be, and you occlude the normal eye, you will see that the lid will get higher because now there is a stimulus for the brain to use it. So the first point about frontalis muscle surgery is that if you want the good result, you need to work bilateral in most cases. The other issue about frontalis muscle surgery is the sling material. And classically, every material in medicine was used as a sling material. Silk, nylon, stainless steel, silk, silicone, every material you imagine was used. The best is definitely fascia lata autogenous from the patient side. I have to remind you that there is banked fascia lata. You call eye banks, they can send you banked fascia lata. Okay? It's not common at all in the Middle East because of the price, but this is available. Why is fascia lata the best? Because it produces good results, very low rate of infections, and very low rate of recurrent ptosis, and we'll understand very now why. But it has two major drawbacks. First, it required surgery on the leg. Most ophthalmologists do not know how to get fascia from the leg. It's not their area. So they don't want to do it, or they don't. Sometimes they ask a general surgeon or orthopedic surgeon to get the fascia. But again, there's a scar in the leg for the patient, long general anesthesia time. The other thing is that fascia lata develops after the child learns how to walk. So it is not available except after 3 or sometimes 4 years, which means that it is not available in the critical time when I need it. At the age of 6 months, 1 year, 2 years, this is when I really need it. It's not available. The alloplastic materials, on the contrary, are very easy to insert. Sometimes they come on an inserter, على needle directly, and you can just pass it under the skin, and the procedure takes 5 minutes. They are always available at any age. However, they have high rate of complications, particularly the infection, the pyogenic granuloma, inflammation, tuck. But the most important drawbacks of alloplastic material, this is typical infections and granuloma occurring with patients with alloplastic materials. I'm sure everyone has seen this. And this is out of the hand of the surgeon. No matter you've done an excellent procedure, you lift the lid in an excellent position, this is inherent in all the alloplastic materials. When you insert an artificial material in the body usually reacts against it. That's ABC medicine. The most problem with alloplastic materials is that the child will grow older, will get taller, but the material will not grow. So if we look into what is going on, we insert a material between the brow and the tarsus, let's say 7 centimeters in a 2-year-old child. When the child is 4 or 5, this distance is now 12, not 7. The child grows, the sling never grows. What happens? The sling will first stretch as much as it can. That's why a lot of people are using the silicone, because the silicone is more stretchable. They think it will last a bit longer than the rest. When it becomes very much stretched, it will act as a cheese wire. I'm sure all of us has once injured their finger with paper. When the sharp edge of the paper cuts your finger like a knife, this is cheese wiring. And this is what happens to all sling materials. After a while, with the growth of the child, they become very much stretched. They start cutting in the tissues underneath the skin. Since in the brow, they are very well fixed either to the periosteum or to the frontalis, and this is more rigid, they start cutting down from the tarsus. So what happens is that they start cutting the tissues of the lid, and the lid starts to droop again. What we need to understand is that all alloplastic materials are temporary in the pediatric population. They will never last long enough. Fascia lata, no. Fascia lata is a free graft. It's a living graft. It will grow the same way that it grows inside the thigh. Okay. So this was the second issue. The third issue is, okay, if fascia lata is the best, how do I get fascia lata? There are several ways of getting the fascia lata. The classic way will entail a 10 centimeter incision in the thigh, because you need at least a strip of the fascia that is 10 centimeter in length. This is a long incision in the thigh that it will remain for a life for the patient, especially if she is a girl. So the stripper was invented. The stripper is an instrument that is very similar to what general and vascular surgeons used for the saphenous varicose veins. You do only a 3 centimeter incision. And I just want to show you all here the stripper, if you can see. The stripper consists of 2 parts. This part ends up here with a very sharp knife, and on the surgeon side there is a caliber, centimeters, written in centimeters. What we do is that we pass the stripper from the 3 centimeter incision. We insert the tip of the fascia lata inside the stripper, and then we gradually pass the stripper the whole length of the thigh until we reach 15 centimeters. As I said, there is a caliber written on the stripper. And when we reach the 15 centimeter, we press on the edge of the stripper, and the knife on the top level will cut the fascia lata above. And we pull the stripper out, it will come with a 15 centimeter length of fascia lata. When you get the fascia lata, the 15 centimeter, you can cut it usually into two halves, one half for the right side and one half for the left side. This is the second way, and this is the best way. The problem is that the stripper is a bit expensive, and it needs a learning curve. At least few procedures where you assist someone or you watch it several times, and it needs a learning curve. But it is definitely better than a 10 centimeter incision in the thigh. A third technique is to open a small incision in the thigh, get a wide piece of fascia lata. You remember that we only need a strip 3 millimeter in width. You get a wide piece, and then you divide this wide piece in the same way like you peel an orange. You know how to peel an orange and get the whole cover of the orange in one piece? That's the same way you start dividing the fascia lata back and forth until you change the wide piece to a long, thinner piece. This is the technique. This way, you got a long piece through a small incision. However, the problem is that the junctions of these pieces sometimes is weak. When you are placing it in the lid, it gets cut. But that's another technique. So we spoke about unilateral versus bilateral. We spoke about the mechanism of working. We spoke about which sling material. Now we need to speak about what I referred to in the beginning, is how to change this procedure from a static procedure with a frozen lid that it moves very slowly or not at all, to a dynamic procedure where the patient can open and close. To understand this, we actually need to speak about the layers of the scalp, because we will place our fascia lata or our sling material in the scalp. The scalp consists of 5 layers, and the word scalp will explain these 5 layers. S for skin, C for connective tissue, A for aponeurosis, which is the frontalis, L for loose areolar tissue, and the last is the periosteum. Where do we place our sling material? At which layer? We actually cannot place it just under the skin. We have to place it between the frontalis and the periosteum, in the loose areolar tissue, in layer number 4. Okay, now if the material is in layer number 4, the material will definitely adhere. Do we want it to adhere to the periosteum, or do we want it to adhere to the frontalis? Do we want it to adhere down on layer 5, or do we want it to adhere up on layer 3? If we allow it to adhere on its own, by gravity, it will adhere to the periosteum, particularly that the child will be lying, sleeping for a long time. So we have to change the procedure to make sure that it will adhere to the frontalis. It will adhere up. We have to suture our sling material, whatever it is, to the frontalis, not to leave it on its own, because mostly if we leave it on its own, it will adhere to the periosteum. How do we do this? There is a step in the surgery that most of us do not do. Here it is. This is the sling material. We passed it through the lid. We ended up in the brow with the two ends. What we do now is that we suture the two ends together, but we also have to create a pocket that extends about 2 centimeters all around the incision, under the frontalis and above the periosteum. So our brow incisions should be deep to the frontalis, up to the periosteum. And we have to create a pocket, a space. And after we suture and we tie both ends together, we pass a suture, a double-armed suture in the knot where we tied both ends of the sling together. Here are both ends of the sling tied together. Then we pass a double-armed suture in the knot. And through the incision, we go with both needles upwards in the pocket, and we penetrate the undersurface of the frontalis to get out of the skin above the incision. Here is the incision. We create a pocket. We pass both ends of the needle to come from the undersurface of the frontalis outwards through the skin to get on the surface about 1 to 2 centimeters above the incision, exactly like here. This is the incision, and here is where both ends of the tying suture came out of the suture. In this way, I have sutured my sling material to the undersurface of the frontalis. I have ensured that my sling material is adherent to the frontalis muscle and will move with the contraction and relaxation of the muscle, and is not adherent to the periosteum, causing a frozen or immobile lid. This step actually differentiates between making this surgery a dynamic surgery with less exposure, less lagophthalmus, good closure, or a static surgery where the patient's eye is always open, sleep with the eye open, does not close well, does not move well. Another surgical tip that we need to discuss is the right facial needle, the needle that we use to pass the sling material throughout the lid between the tarsus and the frontalis. I know all of you have seen the right needle. This is one of the right needles. This is how it looks like. I just want you to understand that there is a pediatric form of the right needle that is less than half the size of the adult form. Here are the two needles, if you can see the difference in size. Please try to use a pediatric right facial needle instead of the usual needles, because this will make the surgery faster and less traumatic for our children.
We can't see it, Dr. Assam.
Random?
We can't see it, just the right needle, the title. There is some picture for it. في صورة ليها؟
أنا موريها دايركتلي.
تمام.
الاثنين عشان
حضرتك مش مشغل هيك احنا مش شايفين الفيديو بتاع حضرتك.
اوكي.
أو يمكن مش ظاهر عندي.
Just realize that we have actually three sizes. Usually an adult size and an intermediate size and a pediatric size. Please use the pediatric size while you're doing the surgery for children. Just to summarize the points about the frontalis suspension, we have to understand when to use it. We We have to understand the value of fascia lata. We have to understand that frontalis suspension is best done bilaterally, even for unilateral cases. We have to understand how to change this from a static procedure to a dynamic procedure. If we really understand all this, then we will be faced by a very simple question. If all this is true, then why don't these are some picture of pre and posts. You can see them everywhere. But this takes us to the other type of frontalis muscle surgery that has been now in fashion, in vogue for the last few years. I just want to tell you that there is a classic session in any good oculoplasty meeting, particularly during the American Academy and the Sobers meeting, that usually compares frontalis link surgery versus maximum levator surgery. For the last 2 years, this session has been changed into a comparison between frontalis link surgery versus maximum levator surgery versus the new procedure, the frontalis muscle flap surgery. What is the frontalis muscle flap surgery? If I understand the idea behind the sling, the good question will arise. Why don't we use the frontalis itself as a sling? Why don't I take a part of the frontalis muscle, rotate it, and make it adherent to the tarsus and act like the sling? Instead of fascia lata that I need to bring from the thigh after 3 years, and instead of all types of alloplastic materials. So the frontalis muscle flap is a technique of direct transfer of the force of the frontalis muscle to the eyelid without the insertion of fascia, suture, or a graft. There's no risk of rejection. There's disease transmission, body reaction. The flap will grow with the child. The frontalis muscle is well developed since birth, so I don't have to wait until the child is 3 years. There is no leg scar. It is not really difficult. It will be definitely a dynamic procedure. And all what I need is 1 2-centimeter brow incision. To understand this, I would like to show you a video. Here is the video of the procedure. I do a 2-centimeter incision just above the brow, usually between the middle third and the medial third of the brow. I dissect until I reach the front surface of the frontalis.
Some no video. We can't see the video.
هو بيتعرض على الشاشة عندي.
أنا مش شايفه. دكتور علي, you can see the video. دكتور علي, تابع معانا, يمكن شايفه إن كان عندنا مشكلة. دكتور علي.
No, I cannot see it.
Okay.
Right. You can still not see the video. I will. Can you see it now?
No, still this PowerPoint presentation.
Right. ثانية واحدة.
السلام عليكم، ازيك يا دكتور احمد؟
كده بان؟
Yes, now it's okay.
Okay. Sorry for that, but here is the video. We do a 2 centimeter incision above the brow. We dissect until we find the anterior surface of the frontalis. We measure 2 centimeter. And then we do an L-shaped incision in the frontalis, which means that we will have a flap of the frontalis with part of the L attached to the frontalis muscle and a free flap part. So this is the L-shaped incision. Cutting horizontally and vertically, having an L-shaped incision. Then we do a tunnel between the brow and the lid crease. This is the tunnel, and we'll exit at the lid crease. We expose the front of the tarsus, and we bring the flap of the frontalis, as you can see now, and we'll suture it to the anterior surface of the tarsus. It's a broad flap that will take about 1/3 of the tarsus. Here we are suturing in the tarsus, making sure it's not full thickness. And we tie. And the more you tie, the higher the lid will come. This is the frontalis flap procedure. Let's get back to the slides. What we have done is that we have changed the direction of a piece of the frontalis muscle, acting as a sling and connected to the front of the tarsus. And the width and the length of the flap can be adjusted according to the power of the muscle, but more importantly, according to the degree of ptosis. The flap actually acts like a harness, لجام الحصان. If you allow a lengthy flap, the lid will not be higher. If you allow a tight flap, the lid will go up higher. So the shorter the flap, the higher the lid, the longer the flap, the lower the lid. And we can adjust the lid height depending on the length of the flap, even post-operatively. If you want to lift the lid up, you can go and shorten the flap. If you want to lower the lid, you can go and lengthen the flap. And these again are some post-op photos. The last tip that I want to discuss with frontalis muscle surgery, whether it is sling or flap, is that the final aim of all what we are doing in kids is to treat amblyopia. Our job does not end by doing the surgery and lifting the lid up. We have to continue to treat the amblyopia and use occlusion and use exercises to maintain and develop binocular vision. Most oculoplastic surgeons think that they've done the good procedure, the lid is up, and that's it. Without occlusion therapy post-operatively, we have done nothing to the patient. We did not benefit the patient. Thank you very much. I hope this have explained my point regarding the two types of the frontalis muscle procedures, the sling, which is what all of us know, and the flap procedure, which is the newest weapon that we have in our armamentarium. Thank you.
Thank you, Dr. Assam, for the nice presentation with tips and tricks in this surgery and the techniques. And now, if anyone has a question or comment, we can hear from them.
Yes, please, Dr. Ahmed. I have a
Ali,
question for Dr. Assam. How long is the L-shaped incision that you make on the frontalis muscle?
This depends on the degree of ptosis. The shorter,
Yes.
usually we start by 3 to 4 centimeters, and then you adjust intraoperatively. So if you want a higher elevation of the lid, you make it shorter. If you want just a small elevation, you make it longer. Again, زي اللجام بتاع الحصان. كل ما تطوله له الحصان يمشي اكتر، كل ما تشد جامد وتعمل الحصان يقرب لك وما يتحركش.
That was beautiful, beautiful. Thank you so much.
Dr. Tarek, welcome, Dr. Tarek. You can ask or comment.
السلام عليكم.
وعليكم السلام ورحمة الله وبركاته. دكتور طارق.
أهلا دكتور طارق.
إن شاء الله بخير. سؤال للدكتور عصام، بالنسبة لحالات التوسز هل تعمل لها بليفروبلاستي with a sling or not؟ يعني أنا أشوف دائما كل ما أعمل توسز الليد إيديما اللي فوق أو السكن الموجود أعمل لهم روتين بليفروبلاستي بيطلع نتائج كويسة. What's about you؟
لو السلينج ماتيريال محطوطة anterior قدام الأوربيتال سبتم you might need to do this دكتور طارق. If you can put it more posteriorly مش هيحصل السويلنج اللي بيحصل في السكن. لكن if you think you need yes we can go in and do it in the same procedure.
Okay, thank you.
I want to make use of the presence of Dr. Tariq. Dr. Tariq is our colleague from Yemen, and the presence of all of us here يعني أننا ننعي الزميلة الفاضلة الدكتورة أمال من اليمن اللي توفاها الله. يا ريت كلنا ندعو لها بالرحمة ونقرأ لها الفاتحة حتى لما نخلص. دكتورة أمال Oculoplastic surgeon في صنعاء، ويعني من خيرة الناس، ربنا يرحمها.
اللهم آمين. دكتور عصام، كان في حد طالب ان احنا نعيد الفيديو تاني، مش عارف حضرتك ممكن تعيده ولا يبقى يراجعوه على اليوتيوب زي ما حضرتك تحب.
لو عندهم وقت ويحبوا تحت امرهم نعيده تاني.
اعتقد هو مش طويل يعني، فممكن نشوفه تاني. هو في حد طالبه على الشات الفلاب سيرجري فيديو.
حاضر يا فندم، ثانية واحدة. حالا بشغله هو يا فندم. اهو يا فندم. تاني احنا بنقسم البراو ل3 تلات، وبنيجي عند التلت الوسطاني وعند الupper border of the brow we make 2 centimeter incision. we dissect لغاية ما نوصل للfront surface of the frontalis muscle. ناخد بالنا ان السكين هنا thicker than the usual lid skin طبعا. I measure the amount that I think is equivalent to the middle third or the middle نص التارسس تقريبا عشان تبقى broad base. And then I do an L-shaped incision, a horizontal incision عند الانسرشن of the frontalis اهو، وبعدين بطلع vertical incision يبقى عندي an L-shaped flap. an L-shaped incision هيديني الفلاب. بديسكت tunnel between my incision and lid crease incision. You can dissect it by any way. أنا هنا باينة بالسيزرز وده بالنسبة لي أسهل، لكن you can do whatever type of dissection you want. فتحت خلاص، بإكسبوز الفرونت، أدي الفلاب بتاعت الفرونتاليس ماسكها وهنزل بيها لغاية ما شايفين الفلاشي ماسل، هاخد فيها السوتشر وبعدين هاخد السوتشر دوت في الفرونت سيرفيس اوف ذا تارسس اهو، باخده في التارسس 70-80% of the thickness عشان ما اعملش penetration. When I tie, the lid will go up. The longer the flap, the lower the lid position. The shorter the flap, the higher the lid position. الميزه انه برودر فلاب انه ما يعمليش ليد نوتشنج، لان انا لو خدت الفلاب رفيعه قوي هتعمل لي ليد نوتشنج. الفيديو هيكون موجود طبعا على اليوتيوب، والفيديو اعتقد يعني هو كمان موجود على ماي فيسبوك بيج، فيعني اي حد عايز يشوفه تاني يتفضل طبعا.
تمام، احنا بس قلنا عشان لو حد ليه سؤال او حاجه او كومنت يبقى على الفيديو، لكن طبعا هو هيبقى موجود في البرزنتيشن وهيبقى موجود زي ما حضرتك اتفضلت على صفحه حضرتك ان شاء الله. Any comment, any question, any what suture size and material do you use, Dr. Assam?
For ايه يا فندم؟
For this flap
605.
605.
مهم السباتيوليتد نيدل علشان does not cut through the tarsus. Always use spatulated needle when you are taking sutures in the tarsus.
Okay. Thank you, Dr. Assam. Thank you, Dr. Ali. Thank you for all our audience. يعني نفع الله بكم جميعا، ونسأل الله سبحانه وتعالى أن يكون يعني علم ينتفع به، وإن شاء الله في ميزان حسناتكم، ونفع الله بكم، وإن شاء الله نلتقي في محاضرة قادمة. السيشن كلها إن شاء الله هتبقى موجودة على صفحتنا على اليوتيوب وعلى صفحتنا على التليجرام إن شاء الله، هيبقوا موجودين البرزنتيشن كامل بالفيديو إن شاء الله رب العالمين. جزاكم الله خيرا جميعا. شكرا دكتور عصام، شكرا دكتور علي.
الشكر للجميع.
نقابلكم في محاضرة قادمة إن شاء الله.
سعدت جدا بوجودك دكتور علي، دكتور براين، دكتور طارق، دكتور سامر، يعني مجموعة كبيرة من الزملاء، ودكتور عمار، أرجو إن أنا دكتورة إيمان، أرجو إن أنا ما أكونش يعني ناسي حد، بس يعني سعدت جدا باللقاء، وأرجو إن الكل يكون بخير وسلامة.
شكرا دكتور عصام، شكرا، شرف لينا والله العظيم.
الله يبارك فيك دكتور عصام، دكتور علي،
شكرا دكتور احمد على تعبك ويانا.
لا تحت امركم، وان شاء الله ربنا ينفع بيكم ويجمعنا على خير ان شاء الله في محاضره قادمه. احنا نشرنا دلوقتي على الشات الرابط برضو بتاع المحاضره على اليوتيوب للي يحب يراجع ان شاء الله المحاضره، وان شاء الله نلتقي في المرات القادمه، والسلام عليكم ورحمه الله وبركاته.
السلام عليكم.
وعليكم السلام.